Great. Well, we're going to follow the same format as this morning with valvular heart disease 2. So we talked about stenotic lesions this morning. We're going to talk about regurgitation this afternoon. So we'll start with this question again. A completely asymptomatic 60-year-old male. He's got low volume carotids, a 3/6 holosystolic murmur with an early diastolic filling sound. EF is 58%. His ventricle is dilated. He's got a flailed posterior leaflet with severe mitral regurgitation. So the next slide will ask you how you want to do this patient. Send him for mitral valve repair, do some invasive hemodynamics, start him on a vasodilator and do follow-up, or follow-up every year. Okay, preponderance of people go into the OR. So we're going to talk about chronic mitral regurgitation. I'm not going to address acute mitral regurgitation, but we're going to talk about chronic mitral regurgitation. Remember, there's primary MR and secondary MR. Think about the AV valves as actually being part of the ventricles they go with. So the tricuspid valve is part of the right ventricle. The mitral valve is part of the left ventricle. If the primary issue is with the valve or the valve apparatus itself, that's primary MR. If the problem is with the muscle, that's secondary MR. So we're going to talk about primary MR first. We're going to compare mitral regurgitation and aortic regurgitation as we go through today. But if you think about the hemodynamic insult of someone with mitral regurgitation, there is pure volume overload of the left ventricle, but there's also decreased afterload when there's severe MR because you've got a low resistance pop-off valve for blood to leave the left ventricle. That's important because when we close that, you will increase the afterload on that ventricle, which will necessarily reduce the EF at that point. So you would expect the EF to be higher than normal when it's got low afterload, and when you close it, the EF is going to drop, and that's an important issue. With both aortic and mitral, as well as tricuspid regurgitation, these long-standing volume overload conditions can cause LV dysfunction that precedes the onset of symptoms, which is why it's so important to follow these. These are more deleterious to the ventricles than the stenosis was. So similar to the aortic stenosis natural history curve, this is kind of the natural history curve of someone with a regurgitant lesion. By the time they get symptoms, they might have had severe MR for a long time, progressive LV dilatation over time, then irreversible left ventricular dysfunction can initiate, and then the onset of symptoms can occur. So our job is to try to figure out how we can intervene soon enough to help this patient. Evaluation of mitral regurgitation, there's plenty of qualitative ways. We all know that we look at an echocardiogram and see how much color flow there is. I think a lot of people still use that as kind of our gut check with all the quantitative techniques we have now. Just look at the amount of MR jet. But remember, there's the issue with jets that hug the walls. They can underestimate the severity. And the converse is true. A jet right down the middle is sometimes overemphasized. And don't step through frame by frame and pick the frame with the biggest amount of MR, because sometimes that's going to overestimate it. This, again, is a chart from the ESC guidelines on management of chronic mitral regurgitation. These are the indicators for severe chronic mitral regurgitation: a vena contracta width of 7 millimeters, systolic flow reversals in the pulmonary veins, E-wave dominant mitral inflow, and then for primary MR, ERO of greater than 40 and a regurgitant volume of greater than 60. There's different definitions of severe for secondary MR which are there. It has been known for a long time that the more regurgitation there is, the more badness there is. So that's why we are using these definitions. We also know that the natural history of severe MR is bad. So at 10 years, 2/3 of patients will have overt heart failure, 80% will have had surgery, or 90% will have either died or had surgery. So severe MR is a progressive disease that will get worse for the individual. Again, if we wait for symptoms to occur, we're going to lose some LV function in people. So yes, onset of symptoms is an indication for operation, but we'd rather operate sooner and improve that long-term mortality. So we want to make sure that we identify people early before the onset of irreversible left ventricular dysfunction. So mitral regurgitation, the low impedance leak, volume overload, the ejection fraction should be higher than normal in severe MR, and the ventricle should be dilated. If you look at the preoperative ejection fraction and survival subsequent to a successful operation, the pre-op EF predicts long-term survival in patients who have surgery. So even with EFs of 50% or less, we already see survival dropping off compared to those whose EF is 60% or more. So really, these would be indications in someone who might not be symptomatic that it might be time to intervene before we lose too much ventricular function. In addition to the ejection fraction, the LV dilatation can also be an indicator. So the guidelines suggest that if the end systolic diameter is greater than 40 millimeters, that would also be an indicator of LV dysfunction that's already initiated. So we call this the 60-40 rule of mitral regurgitation. Other indicators that you might use to do an earlier intervention on someone with mitral regurgitation are if they're developing pulmonary hypertension, if they're having new onset atrial fibrillation, or again, poor exercise performance. And I'm a big fan of using exercise tests for valve lesions, as you've seen through the talks this morning. I think that we have many patients who underreport their symptoms or underperceive their symptoms. They've had these long indolent courses and they aren't aware that they could be able to do more. And I like to use exercise tests to tease that out. So ideally, we would like to operate on people before LV dysfunction takes place. We do have data that shows that early intervention, even in asymptomatic people that don't have signs of LV dysfunction, that early operation by experienced operators improves long-term survival. It's predicated, though, on a successful surgical program and repairable valves. Remember, a mitral valve repair is a much better outcome for someone than a mitral valve replacement. A posterior leaflet flail is almost an automatic repair on any surgical, any experienced surgeon. Anterior leaflets are slightly more difficult. Calcium can cause challenges for surgeons. So mitral interventions for primary MR are severe MR and any symptom, severe MR and a decompensated LV defined by 60% or 40 to 45 millimeters end systolic diameter. And if you have procedural success rates in excess of 95% and mortality rates of less than 1%, then operating for these other higher risk features is a reasonable circumstance. So in this first question, this 60-year-old man already has an EF that's decompensating. So he has severe MR with a decompensating LV. He's a reasonable person to offer a mitral valve repair to. We'll move on to secondary MR. Usually this is due to dilated cardiomyopathy or heart failure or an infarct. There is mitral annular dilatation, but there's also apical displacement of the papillary muscles as the ventricle gets bigger, which pulls the mitral leaflets into the ventricle. There's this tenting phenomenon, so there isn't redundancy and coaptation. As Dr. Prendergast talked to us about this morning, the success of surgical intervention on secondary MR is not near as high, and it's confusing based on the trials that we have out there right now. Generally speaking, we want to treat the ventricle as best we can, and if we then still have severe MR, then you can consider intervention. These were talked about this morning, so I'm going to skip over this slide for time. This is what the European guidelines have listed as the way to approach secondary MR using ejection fraction dichotomized at 30%. And those who have an EF of higher than 30%, you will revascularize that patient if possible and consider an MVR during that operation. If there are no revascularization options, optimal medical therapy, which might include things like CRT, to see if we can't get that ventricle better. And if they still have severe MR and still have symptoms at that point, then you might consider a mitral valve repair or replacement in a low-risk surgical candidate or an edge-to-edge clip, the mitral clip, if they're a higher risk patient. For the super low EF patients, again, consider revascularization if that's an option. Otherwise, it's optimal medical therapy backed up by a clip if need be. You can simplify this graph, take the EF out of it. Are they revascularizable? Do it. If they're not, optimal medical therapy, and then consider whether you need to do any mitral intervention from there. Let's move on to this next case. We're going to switch valves again. So here's a 20-year-old asymptomatic male, heart murmur since childhood, bounding carotids, a 2/6 systolic ejection murmur, a long diastolic decrescendo murmur. He's got a dilated LV. His EF is 59%, bicuspid aortic valve, mean systolic gradient of 12, severe AR, and then, again, dilated numbers, and systolic 40 and diastolic of 60. What will we do to this gentleman? Seems like the second question in all my series, there's more divergence in opinions. All right. So talking about chronic aortic regurgitation here, as opposed to MR, there's both increased preload and increased afterload with the aortic regurgitation, which means the EF isn't going to drop if you fix AR. So that's one of the differences, because there is this afterload mismatch when you're trying to push all this blood volume back out of fixed aortic annulus. EF makes a difference in aortic regurgitation. If the EF is less than 50%, patients do worse than if it's higher than 50%. So that's going to be our cutoff value for considering LV dysfunction and aortic valve regurgitation. So again, in this same scheme of regurgitation lesion, LV dysfunction has occurred when the EF drops to 50%. Severe is defined by these parameters: 6 millimeter vena contracta, pressure half-time of less than 200, regurgitant area of 60, regurgitant volume of 30 and 60. I find AR to be one of the hardest things to assess in the echo lab, actually. I think MR and the other things are easier. I think AR is just more challenging. So you have to use all those other secondary things. Are there reversals in the aorta? Are they in the descending aorta? You can do the TVI of the regurgitant signal, et cetera. But it's a more challenging one to deal with. And the course can be longer than in mitral regurgitation. Beware of just comparing LV or AR jet area to LVOT jet areas. Those things are just fraught with errors in tracing these signals and getting eccentric jets that are cutting across. So be really careful about that. And again, look at the flow reversals in the thoracic aorta. So again, we want to operate at the onset of symptoms if they're there. We want to operate if there's LV dysfunction, LV dilatation. So what about this issue of vasodilator therapy? We probably should get rid of this slide because this is actually now 25 years old, that no subsequent study has shown that vasodilator therapy improves the natural history of aortic regurgitation unless the patient has concomitant hypertension. So if a patient is hypertensive and not treated, use a vasodilator to treat that person for their hypertension. Otherwise, there's no particular role for vasodilator therapy in these patients. Now, there are multiple numbers for LV dysfunction. Again, we generally talk about, I said the 60-40 rule with MR. We use a 50-50 rule in aortic regurgitation, so an EF less than 50% or an end systolic diameter of more than 50. The European guidelines use 55 as their cutoff. I would also remember this one. 25 millimeters per meter squared, which helps normalize to body surface area. So if you have a smaller stature person, and often women fall into this category, look at the end systolic volume divided by body surface area to see if that LV is really dilated, and patients who need intervention if it's more than 25 millimeters per meter squared. There's also these numbers of super big ventricles with an end diastolic volume of 7 centimeters or more. That's a big ventricle and probably warrants your radar going up and thinking about doing something with that patient. So this is the management of chronic aortic regurgitation. First, look and see if there is significant aortic enlargement. What does that mean? Well, for anyone whose aorta is greater than 55 millimeters, that person probably needs an operation to avoid dissection. If they have a bicuspid aortic valve or Marfan syndrome, then you might drop that to 50 millimeters. And if they have one of the higher risk forms of thoracic aortic disease, say a Marfan history plus a family history of dissection or a Louis-Dietz syndrome, then you're going to want to intervene when that aorta gets above 45 millimeters. In the absence of an aortic reason to fix AR, then we look at these other things. So again, is it severe? Do they have symptoms? Here's another rule for treadmill testing. If the symptom status isn't clear, are they truly symptomatic or not? The 50-50 rule, those all lead to AVR. If they're completely asymptomatic with an okay ventricle or they don't have severe AR, then you should be following them. We tend to follow our severe patients every 6 months and the less than severe patients every 1 to 2 years. So in this individual, he was active and asymptomatic. His EF was still normal. He's just at this cutoff value of 40, so we would probably watch this person and bring him back in 6 months. So, summarizing these left-sided regurgitant lesions, severe regurgitation and symptoms intervene. A drop in EF intervene. Marked LV dilatation intervene. And if you have a primary severe MR and repairable valve, you might even operate sooner on those people with flail or prolapse because it is inevitable that they will have an operation. We'll touch briefly here on tricuspid valve regurgitation. It follows a lot similar to mitral regurgitation. You know the clinical presentation, it's signs of right heart failure. One unique aspect is if you're operating on a person for left heart disease, you might consider our tricuspid valve operation at the same time. Obviously, if they have severe concomitant TR, you're going to go ahead and fix that if you're in the heart anyway. But even if they only have moderate TR, if they have a dilated tricuspid annulus or signs of right heart failure, you might try to do a tricuspid valve repair at the same time as the left valve surgery. If the tricuspid annulus is normal and there's no right heart failure, then you probably don't intervene on that tricuspid valve. In the absence of left-sided valve disease, this is what the algorithm says in the ESC guidelines. For primary TR, if they're symptomatic, you do it. If they're asymptomatic but they have signs of RV failure, just like in the mitral side, then you would consider tricuspid valve intervention. Secondary MR, LV or RV dysfunction or PH, consider operation. If the RV is okay and the patient's asymptomatic, you can follow. You can make this really simple. Tricuspid valve surgery is indicated for severe TR and symptoms, ventricular dysfunction, or at the time of concomitant left-sided valve surgery. So this is my summary slide. For valvular regurgitation, the ventricle can decompensate before symptoms. It's why when we start detecting MR or TR or AR, we start doing echoes more frequently in those people. Particularly when it gets severe, you're gonna echo them every 6 months. Intervene on severe regurgitation for symptoms, ventricular decompensation, or ventricular dilatation. Thank you.